I think we will have the question and answers at the end of the session. We will straight away go into the next topic for the multiple cranial palsies. It's going to be dealt with by Dr. Vijayashankar, who is the head of the neurology at Apollo Hospital, Chennai, and someone who specializes in the movement disorders. We are happy to have him today, and the stage is yours, Dr. Vijayashankar.
Good morning, everyone, and thank you for D Club for giving me this opportunity to talk about the common cranial palsies and their management. This lady, she came to me with headache for 10 days, with a tiredness, fatigue, and initially she was treated by a local doctor for just with a paracetamol and zithromycin, because she told that she was tired, fatigue, some discomfort. So it was thought as usual sinusitis. So with the paracetamol, suddenly after 10 days she came with sudden blurring of vision. She told that it was very blurry, I'm not able to see properly. The one history, she told me that she is having difficulty in chewing the food. So what could be the diagnosis? Yeah. So any new onset headache, jaw claudication, always in the older people, always think about a jaw claudication. It's always temporal arteritis. So initially the MRI was done, MRI was normal, but when you had done the ESR and CRP, both were high. So we have asked for a temporal artery Doppler. So the temporal artery Doppler, usually in a temporal arteritis, mostly the MRI may be normal. So first thing we'll think about any headache, do a MRI. If MRI is normal, we'll struggle. We'll think about it's a migraine, we'll start all the medication. But nowadays we see temporal arteritis very, very commonly because it's a medical emergency, like that neurological emergency. If a patient with temporal arteritis, always send the patient to temporal artery Doppler, and if you see this type of halo sign, most of the patient will have generalized body pain, polymyalgia, rheumatica. In this case, always start the steroids yearly. That's very, very important, because if you don't start the steroids yearly, the vision will be lost and it is difficult to recover. And also, we need to send them for a temporal artery biopsy. So I have sent the patient, started on steroids. Second, I told them to get admitted. They came and they got admitted. We have done a temporal artery biopsy. Temporal artery biopsy was normal. This always we see. So I thought it's a temporal arteritis. If it is going to be temporal arteritis, the biopsy should show something. It was negative. The next question: should I continue the steroids or should I stop? This is what the question we have the problem. The issue here is two possibilities. One, when you start the biopsy, there is a skip lesions are very, very common because the temporal artery is big. When you do the biopsy, if you take a small biopsy tissue, there is a high chance that biopsy may be missed, the lesions may not be there. Or sometimes, because we are starting the steroids yearly, because we are trying to save the vision, if you delay the biopsy like 3 or 4 days, there is a high chance the steroids will reduce the inflammation. Obviously, the biopsy will be normal. So, no need to worry. If you have a halo sign, don't worry, continue the steroids. That's very, very important. So, if you suspect giant cell arteritis, don't worry about the biopsy, start steroids and continue for steroids, first 500 mg to 1 gram for 3 days to 5 days. Then followed by oral prednisone. Wait for the patient. If the symptoms reoccur, then there are new medications such as tocilizumab is available. Then we can start the tocilizumab. So the important point is, if a patient with new onset of older patient, headache with jaw claudication, always suspect giant cell arteritis. Always look for ESR and CRP. Recently, when I started the practice, I always send ESR. Many times ESR will be normal. Recently I had a patient, somebody suspected giant cell arteritis, they are sent only the ESR. ESR is normal. The problem is I send the CRP. CRP is more specific than the ESR in giant cell arteritis. So do CRP also and start the steroids. Another diabetic, 66-year-old diabetic patient, sudden loss of painless monoocular vision loss. MRI is normal, no limb weakness, no pain, just a vision loss. What do you think? Stroke, optic neuritis, or retinal disc, CRAO, BRAO, the amaurosis fugax, or non-arthritic optic neuritis. So in this patient, if you see, the upper half of the vision is lost. Only the lower half of the vision is preserved in a diabetic. So in this case, always look for RAPD. RAPD means if you flash the torch, one eye will be normally opening, others will be like usually when you flash the torch, the pupils will be constricting. But here in RAPD, the pupils will be dilating instead of constriction. It's opposite effect. And sometimes they can have a disc edema. The altitudinal vision loss is always suggestive of non-arthritic anterior ischemic optic neuropathy. In a diabetic, sudden vision loss, painless vision loss, always suspect non-arthritic vision loss. The important thing is this is also another medical emergency in a diabetic patient. If they have this type of vision loss, always ask for ESR, CRP, because as we discussed giant cell arteritis, that is one of the most common cause in the elderly. Other one is diabetes is another. Diabetes is another common cause. So always ESR and CRP is very common, and do a MRI because most commonly we see this in a strokes. If stroke is not there, always suspect non-arthritic optic neuropathy and start yearly steroids. That's very, very important. In this type of vision loss, because even if a stroke we can recover, but if eye is affected, it is a neurological emergency. We cannot recover. So we need to start the steroids at the earliest in these type of patients. So tight control of diabetes, hypertension should be controlled properly. Lipids, the main thing is sleep apnea. Many times we don't consider sleep apnea as a problem. So sleep apnea has to be considered and treated properly. So as I told you earlier, check for ESR, CRP. Look for pain or painful or painless. Painful means it is a optic neuritis, most likely a multiple sclerosis. Painless, diabetic, optic neuritis. Okay. So this gentleman came with early ptosis of eyelid, gradually onset. Mostly commonly his eyes were normal in the morning, afternoon and evenings he developed double vision or sometimes ptosis. So fluctuating, MRI normal. We all know this one. Myasthenia. Always in a myasthenia, the simplest test, bedside test, what we can do is, look for fatigability, a Cogan sign. Cogan sign is ask the patient to look down and up. Usually, when you're looking up, usually the eyes, for us, it will be like this. Just look at, it will stay in the center of the eye. For these patients, it will go up and come. That's Cogan sign. But the easiest and the bedside test is keep your eyes back. It's easily, we can do it in the clinic itself. If the patient is having ptosis, if you keep the eyes for a few minutes, automatically the eyes will open. This is one of the highest specificity and sensitivity tests. We can easily diagnose this patient in the clinic itself. No need for high-fi test. If your eyes test improves the diplopia, always it is myasthenia. Easily we can diagnose this one. So it's very common in younger patients, but we frequently see this type of patients. They will think that okay, it's a myasthenia. We will send for AChR antibodies or Musk antibodies. Most often it will become negative. Immediately patient will come. So enna sir myasthenia and sonninga ellame negative argu. So we'll also get a doubt. Am I really? And because AChR is the commonest test we see for myasthenia. Both are negative. Should I start a steroids or should I start before that itself we'll be more confident. I will start a Gravita. and he will say, come and say, sir, கொஞ்சம் பெட்டராக இருக்குது, ஆனால் டெஸ்ட்லாம் நெகட்டிவாக இருக்குது, கண்டினியூ பண்ணுமா வேணாவா? This is a catch situation we'll have always. But the important thing is, there are two types of myasthenia we have. One is generalized myasthenia, we all know. They will have speech problems, swallowing problems, the proximal weakness, difficulty in raising arms, sitting to standing. But the subset of patients who has is a ocular myasthenia. In ocular myasthenia, only 50 to 60% of the patients can have the antibodies positive. Remaining 40% of the patient may not have antibodies. In that case, even though if it is negative, we can continue the like Gravitar and steroids, they will improve. So even though if the test is negative, don't worry, it is myasthenia, nothing else, ocular myasthenia. So just start pyridostigmine. If it is not improving, add steroids. The only thing is we can start steroids, but if it is going to be a generalized myasthenia, usually when we are starting steroids, we always start 1 milligram per kg in a normal patients. But if you are suspecting myasthenia, don't start high dose of steroids, because sometimes at least over the time 60 to 70% of the myasthenia will become generalized myasthenia. If it is going to be a generalized myasthenia, if you start 1 milligram per kg, there is a high chance sometimes myasthenia can suddenly worsen and they will end up in a myasthenic crisis. So the dictum in myasthenia is, if you are starting a steroids, start low, like 10 milligram. Then every week build up 10 to 20, 20 to 30, 30 to 40. Usually around 40 to 50 milligrams, usually most of the patients will respond well. So I have enough number of patients. We always, patient will be around the impending crisis, slowly difficulty in speech, swallowing, so we will be more, because money is the problem for them, because if they end up in myasthenic crisis, we have to give IVIG or plasma exchange. That will cost around 5 lakhs, 6 lakhs, all this in hospital stay. Sometimes they go to ventilator tracheostomy. It is difficult to bring them out immediately. So sometimes we'll build the steroids a little bit faster. Every 3 days, 5 days, sometimes if you increase the steroids rapidly, they will worsen. So be careful with myasthenia alone. The other point, important point is, if you are suspecting myasthenia, many antibiotics can worsen myasthenia. Like safest antibiotic is the cephalosporins and the augmentin. These are all the very, very safest medication, because many other medications can worsen myasthenia. So be careful with myasthenia. Another diabetic, looking sudden double vision, looking at the left is fine, but if you look at the right eye, looking at the right side, it is not possible, it is restricted. So looking up and side is fine. Look at the right eye, the lateral rectus medial is fine, the lateral rectus is affected. We always know diabetic lateral rectus palsy. What to do? The common thing, anytime what we'll think is diabetic lateral rectus palsy, start steroids. But he is a diabetic. Already namakita varavalla 300 400 da vechittu varuvan, evanu kammiya varamatan. So in that case, will you start steroids or not? Sugars adhigama irukku. The easiest concept what we initially practiced was, vision is more important, lateral rectus is more important. So we can manage the diabetes, insulin potukalam. Abindha we'll do what, that's what we have standardly, like years together we practice. So start steroids, 500 mg methylprednisolone, and sugars அதிகமாகும் சொல்லிக்கலாம். 5 நாள் அப்படி தான் இருக்கும், பார்த்துக்கலாம். நம்ம அதெல்லாம் கொஞ்சம் அப்புறம் மிச்சம் மெதுவாக ஸ்டாப் பண்ணோடனே குறைஞ்சி போயிடும், பார்த்துக்கலாம் அப்படின்னு சொல்லிட்டு வில் ரெடியூஸ் த ஸ்டெராய்ட்ஸ். மெதுவாக குறைஞ்சோடனே சுகர்ஸ் குறைஞ்சி போய்ட்டு டில் தட் டைம் வில் மேனேஜ் வித் வந்து இன்சுலின். திஸ் வாட் ஸ்டாண்டர்ட் ப்ராக்டிஸ் வி ப்ராக்டிஸ். ஸோ as I mentioned, isolated lateral rectus palsy, no pupils, always look for pupils, because if pupils are involved, always do a MRI, especially MRI angiogram, because if pupils are involved, the pupils are in the center. Okay, central, if it is affected, usually it is a aneurysm. So sometimes they get painful or painless. Aneurysm bleed aachna painful aagum, aneurysm bleed agala, it's painless. So pupil sparing alyan, first we need to look into it. So look for other cranial nerves. MRI should be normal. The problem is nowadays the guideline shows there is no need to start steroids in these patients because it's a small vessel ischemic diabetes induced small vessel ischemic disease. So no need to rush, no need to start steroids. Control the diabetes, that's more than enough. Okay, so the isolated in a diabetic, we commonly see the isolated cranial palsy, that's common, and control the diabetes, control the hypertension, control the lipids, look for vasculitis. If there is vasculitis, commonly we see vasculitis with diabetes, like many patients have vasculitis. If they have evidence of vasculitis, then start steroids. If there is no vasculitis, no need to start steroids. Just tell them, yes, you have got a lateral rectus palsy. It will be there for a long time. You may have diplopia. There are prisms are available. Or sometimes if the severe diplopia is there, we can give you or shaded glasses are there, or closing the eyes, one eye. Because if they have a diplopia, obviously they will have double vision, difficulty in concentrating, they will have headaches. So all this like a non-pharmacological measures are there. We can use those till it recovers. So the important thing is, if a young patient, not only the lateral rectus palsy, like if they have multiple cranial palsy or any persistent headache, not improving over the time, always do a MRI. Okay, the MRI may show some other involvement, some other problems in the brain, especially some patients usually like Tolasa syndrome. If the headache is there with lateral rectus palsy or other cranial, always the orbital apex is very, very common. Tuberculosis or sarcoidosis, vasculitis are more common in these patients. So the common thing which we see, young male with a deviation of angle of mouth, unable to close the eyes. They will say typically when they chew, they are not able to chew. Drooling of saliva is there. When they brush or gargle the mouth, they will have a drooling of saliva is there. It's typical, we know, Bell's palsy. But always, if a patient is having Bell's palsy, it is our duty to differentiate whether it is a LMN sign or is it a human sign. That's important. Like ask the patient to wiggle the eyebrows, because if it is LMN palsy, most of the half of the face is affected. Like the eyebrows, they cannot do the eyebrow wiggling, or if you wiggle, only the wrinkling will not be there in a LMN facial palsy. If it is a human facial palsy, only the lower half is affected, only the deviation of angle of mouth will be there. If it is going to be a human palsy, always suspect a stroke, because many patients just facial palsy alone can be there without the limb weakness, because sometimes it can affect the thalamus. They can have some sensory loss alone. Sensory loss they will ignore, they will not tell us. So we need to do a MRI. First look at a human palsy or LMN palsy, then we can decide what else. And always look for the ear pain, because when the patient is having a ear pain, usually it can be a Ramsay-Hunt syndrome, because it's a viral illness. Usually they will have a mild ear pain, and within a week they will develop a vesicles. It could be a Ramsay-Hunt. If you start like a acyclovir, they will respond. Or most commonly in our settings, what we see is it can be a ASOM or CSOM, because the facial nerve just comes closer to the facial canal. Mostly the ASOM, CSOM will be useful, because if it is going to be a facial palsy, we always start steroids. That's very first line of treatment. If you start steroids for ASOM and CSOM, obviously it can worsen the infection, so be careful with that one. So nothing, no steroids, no MRI required, no blood test is required. Start your steroids 50 to 60 milligrams for 7 days. That's important. And many people, okay, like they'll do, whether the patient is on steroids 5 to 7 days is enough, or 5 days of 50 to 60 milligram, like tapering dose, like 40, 60, 60, 50, 40, like another 5, 6 days we can taper also. Both are fine for us. For a routine, every day, if a patient comes to Bell's palsy, we start about 2 things. One is a steroid, next is acyclovir. Do you want, is there any role for acyclovir still? Should we start it or not? Any idea? Because this is what we say. Every patient start லைக் சர்வலோக நிமாட்டிமா டப்பு போட்டு அனுப்பிச்சி விட்ருவோங்களா. அந்த ஃபேஷியல் பேல்சி பார்த்தா வில் ஆர் வெரி ஹாப்பி. ஏன்னா நியூராலஜிக்கல் பேஷண்ட்ஸ்லாம் வந்தாங்கன்னா 1/4 மணி நேரம் 1/2 மணி நேரம் எக்ஸாமினேஷன்லாம் போகும். பெல்ஸ் பேல்சி பார்த்தா போதும், வித் 5 minutes எங்கள் ஒர்க் முடிஞ்சு, ஹெடேக் அண்ட் பெல்ஸ் பேல்சி வில் ஃபினிஷ் ஆஃப் அண்ட் சொல்லோ அப்படின்ட்டுவோம். பட் இம்பார்ட்டன்ட் திங் இஸ் நவ் there are lots and lots of evidence are coming. The evidence shows that there is no role for acyclovir nowadays. But the problem is most of the studies are done in abroad. நான் அப்ராடில் போய் என் பாஸ் கிட்ட வந்து I talk about infection. They usually say, பா நீ சொல்கிற மலேரியா, நீ சொல்கிற இதெல்லாம் நான் பார்த்ததே கிடையாது, எனக்கு தெரியாது. மை பாஸ் இஸ் ஒன் ஆஃப் த பெஸ்ட் இன் த வேர்ல்ட். எந்த கேஸ் கொடுத்தாலும் he will crack it. He is that much of brilliant. He is considered one of the best. அவர் சொல்லுவார், he came to India 3 times. நம்ம போட்டதெல்லாம் நம்ம இந்த இன்ட்ரெஸ்டிங் கேஸஸ்லாம் போட்டதெல்லாம் பார்த்தா இன்ஃபெக்ஷன் ரிலேட்டட் மூவ்மெண்ட் தான், டியூபர்குலோமா, அது நியூரோசிஸ்டிக் சர்க்கோசிஸ், அது ஏதாவது ஒரு மூவ்மெண்ட் சொல்கிறா வரும். They will say, whenever I go to India, I will tell them, except whatever the autoimmune, all the cases he'll crack up, but infection I always fumble because they never see an infection. So all these studies are done in abroad, they never seen a infection, so they don't recommend acyclovir. But in Indian scenario, yes, there are lots of evidence shows that yes, acyclovir is useful, and use the acyclovir for 5 to 7 days and steroid as for 5 to 7 days. But important thing is start all the acyclovir or steroids within 72 hours. That's very, very important. Start the steroids and acyclovir early, and if the patient is having troubles, cornea, because they cannot close the eyes, so we need to patch up the eyes, teardrops, all these things very, very important. The next common thing, vertigo. We commonly see this patient, sir, தலையை திருப்பினா இப்படி திருப்பினா லைட்டாக தலை சுற்றுது, என்ன பண்ணுறது? This is the common thing we have. So in this case, commonly we need to, history is very, very important in this patient. In which position the vertigo occurs, that gives the clue which canal it is affected. So if somebody presents with a vertigo on looking up, it means it is occurring in the posterior canal. So looking up is posterior canal. If somebody says they are rolling up in the bedல தலையை திருப்பும்போது தலை சுற்றல் வருதுன்னா, that is a horizontal canal. Or if you are bending down, like a shoe கட்டும்போது கீழே குனியும்போது தலை சுற்றல் வருதுன்னா, this is a anterior canal. Why it is important? We all give, like வந்தவொடனே வெட்டின் 8 mg போடு பத்தலையா, 16 mg போடு பத்தலையா, ஸ்டெமிட்டில் போடு, ஸ்டூஜரான் போடு அப்படின்னுவோம். But the problem is, these are all easy. If the patient settles down, we are also happy, they are also happy. There are some troublesome patients are there. சார் நான் நீங்கள் கொடுத்தீங்க, ஒரு மாதம் நல்லா இருந்துச்சு, ஒரு 3 விட்டோடனே மறுபடியும் வந்துடுச்சு. சில பேர் தட் ஆர் ஆல்சோ ஃபைன். சார் நான் மாத்திரை போட்டேன், நிறைய தூக்கம் வருது, மாத்திரை குறைங்க. ஸோ ஆப்வியஸ்லி வி கேனாட் கிவ் இட் மோர், பட் வென் யூ ரெடியூஸ் இட் அகைன் த சிம்டம்ஸ் வில் பி மோர். They will have persistent symptoms. In those troublesome patients, it is difficult for us. You can see this girl is an area posterior. She has got it's a NMO spectrum disorder, but she has got a upbeat nystagmus, almost similar to the posterior canal nystagmus, upbeat nystagmus. So the important thing is, the easiest thing is recognizing which canal is affected. There are some easy maneuvers are there. If it is like a posterior canal, we can do a Epley's procedure, like turning head. It is easily available in the internet. Epley's maneuver. If it is going to be a horizontal nystagmus, the barbecue roll. If it is an anterior canal, deep head hanging, these type of procedures are there. If you do the procedures, usually the patient will respond. These are all easy bedside procedures. We can improve the patient, but it is rewarding. Sir, they will say, sir, last time நீங்கள் பண்ணீங்க உடனே சரியாக போயிடுச்சு சார், நான் எல்லா இடத்துலையும் மாத்திரை சாப்பிட்டா சரியாகல அப்படின்னு. These are easy tests. We can easily do it in our clinic, and we can score the marks easily with the patients. So, and sudden onset of slurring of speech, difficulty in swallowing. The problem is, this gentleman came with a right-sided facial numbness, left-sided weakness. We all know that if there is a hemiparesis, it should be one-sided. But here, crossed, right-sided face, left-sided body. We always get confused. How can it be a hemiparesis? Yes, that's what. It's a brainstem cross deficit. Always it's a medulla, because the fibers crosses there. So it is a lateral medullary syndrome or Wallenbach syndrome. So usually it can be a brainstem stroke, or a patient can have Horner syndrome, like pupils will be small, and also ptosis can be there. Mainly they can have a vertigo or hiccups can be very, very common. It's a crossed hemiparesis. So do a MRI brain. This, I have two patients, same. They had the crossed hemiparesis. I know that, yeah, this is lateral medullary syndrome. I have done a MRI now. So I cannot explain. Patient is telling, so we have done all the tests. Once it is negative, now we get panic. No, they are negative. So we do all the tests. So usually, if it is going to be a posterior circulation stroke, there are many times the stroke may not be seen immediately. So many times they come with a vertigo. Slowly they will have a clinical features of stroke. Second day, third day, they can show the diffusion restriction in the MRI. So don't be panic, be confident, repeat an MRI after 3 to 4 days. But many times what our patient is, sir, 3 நாளைக்கு மட்டும் MRI பண்ணா மறுபடியும் பண்ண சொல்றீங்களா அப்படினுவாங்க. So we always told them, no ma, there can be infection, we'll do a contrast. So we do a contrast, but obviously the reason is they will not accept for the this contrast, or we'll say MRA, MRB, deep we'll do a repeat MRI. Obviously we'll get the lesion. I have a patient, within week 4 times we have done three MRIs. Every third day we have done, it was negative. Fourth MRI we found it. Especially a small stroke can be missed in this type of patients. And slurring of speech, this type of swallowing difficulties, and difficulty in swallowing, nasal twang, and weight loss, sensory symptoms. Always look at the tongue, it's atrophied. This is very commonly we see in our practice. Is it a stroke? And look at the video. Always look for a fasciculations of the tongue. When the tongue is atrophied, look for fasciculations. The patient can have not only the fasciculations, they can have fasciculations in all over the body. This is motor neuron disease. There is a subtype of motor neuron disease. They cannot have any weakness or nothing in the whole body. Usually the two ways, it can start in the limb and can progress to the swallowing problems, tongue atrophy later on as a part and parcel of the disease evaluation. The other way around also is very common. They can have a tongue atrophy, swallowing difficulties, speech problems, then slowly evolve into a generalized motor neuron disease. So it is very, very difficult for us to treat because we don't have much of a treatment for this patient. Always in clinically look for a brisk jaw jerk and look for the other reflexes. Usually in a motor neuron disease, the other reflexes may be brisk, and also atrophy can be there. Extensor plants are common. Always first thing is look for a MRI. If MRI is negative, put a needle EMG. The EMG always shows it could be a motor neuron disease, and always we think that it could be a motor neuron disease many times, but it can be a myasthenia also. Myasthenia mimics like a motor neuron disease. Always, if you suspect a motor neuron disease, autoimmune diseases, especially the paraneoplastic cancer-related diseases are very common. Do ACHR, MuSK, and cancer tests. So nowadays we always give riluzole, but nowadays the problem is they cannot swallow. Nowadays the edaravone liquids are available. These things can slow down the disease process or little bit prolong the disease process. And commonly what we see in our movement disorder practice, any patient comes with a slurring of speech and suddenly like this type of lips backing, otherwise no other symptoms. Yeah. Twitching of the lips like this, the twitch. Very, very common. So if anybody, we call it as a rabbit syndrome. Like any patient who comes with the perioral movements like this, or tongue it will be going like this, slurring of speech, always ask for what all the tablets they are taking. The most common culprit is domperidone and levosulfide, because we left and right we use a pan D, pan L, left and right, that's the culprit. But if you ask them to bring the prescription, they will say a prescription maybe 1 year back somebody would have written the pan D, nothing will be there. And if you ask them, they don't know what is the name, most of the village patients and all. If you ask them to bring what all the tablets they are taking, obviously they will come and show. Sir, in the tablet, no, sir. They will not, they don't know what is Pandi gas tablet, sir. So, obviously, if you see there is a domperidone or levosulfide, stop the tablet, obviously they will become better. And if only thing is how long you are using the tablet. If you are using the tablet for a short time, it will settle down within a month. But sometimes some patient takes longer time to recover. In those patients, tetrabenazine or even Botox we give, that responds very well. Thank you.
Thank you, Dr. Vijayashankar, for your enlightening lecture on cranial nerve palsy.